Okay. How many participants we have? 98. So I think Arslan, should we start? If yes,
Yes, we can
please.
begin.
Okay. Thank you so much, everyone, for joining us. Please type in the chat box if I'm audible, so we can start officially.
Right.
Yeah, okay. Thank you so much, everyone, for joining us today. We will be having an interactive webinar today, or sort of a podcast today with Dr. Nabil. And this topic is a very pertinent topic and is essentially very neglected during when we study the global health, and we will be discussing global surgery and the access to emergency surgical techniques and different anesthetic approaches towards especially when we talk about the different situation in low middle income countries and Pakistan and India, as we have been joined by different participants today. So over to you, Dr. Nabil. Can you please give us your short introduction so we can start?
Hi, everyone. Nabil here. I am a graduate from Aga Khan University in Pakistan. The university is in Karachi. And in the last 2 to 3 years since my graduation, I've been working on global surgery. It is an honor to be speaking to all of you. I was not part of IFMSA when I was like a student, but I got to know about IFMSA when I started interacting with a lot of colleagues in my global surgery community, and realized what a brilliant platform IFMSA is for people to get to know about public health and to get to know about issues and ways we are trying to tackle health inequities across the world as a community of global health. So today we will be discussing the challenges faced in providing safe, affordable, accessible surgical and anesthesia care across the world, and how it is impacted by economy, by social factors, and how it itself will impact economy, social factors, environment, etc. So for this session, we've tried to keep it like a conversation between me and Adil, and as we go along, you will get to know a lot of different new information, maybe information that you already know about, but I've tried to structure it so that it is beneficial in this global health delivery programs, webinars. And so over to you, Adil. That's all from my side.
Thank you so much, Dr. Nabil, for your kind introduction of the topic. So today, as we all have gathered here to discuss about the global surgery, and as the name of our project indicates, that we will be discussing about the healthcare delivery system, how we should approach towards the low middle income countries population when we talk about the universal health coverage, or we talk about delivery of the quality healthcare services towards the different population based in Pakistan, or like in different countries based on their economy and based on their income. So I would be asking Dr. Nabil quite question that you guys have shown us, that you guys have shared with us. So it would be a kind of interactive session. So I would move towards my first question is, I would ask Dr. Nabil is, what do you think, like, according to you, what is global health and what is global health delivery? So how do you define you according to yourself? Like, you have been working in the field from very long. So how you define that, and what are your target? How you will, incorporate that into our daily life?
So I wish we could have a more interactive session, but it's just like the pandemic and everything. It's quite limiting. But global health is the definition of global health. It's debated all over the world. over the world. But what is coming into more mainstream acceptance is that global health is basically public health on a global level, and which makes me think about what public health is, and should make you guys think about what public health is. And public health is not just about prevention and health promotion. It's more than that. What is happening is that people are starting to think of health as a product of society. There's a part about an ecological model. Um, it would be great if anyone knows about what an ecological model is. For me, it was a very new concept when I started reading about global health. What the ecological model says is that we in a society have different um, political, economic, social, and environmental norms and structures that impact how we interact with each other and how our interactions will lead to various outcomes. So one of the outcomes that is affected by these structures is called health, and public health is about understanding these complex interactions and understanding how they impact the health of populations, not just individuals but populations. With globalization, like how we are today, we are basically so connected through the internet, through air transport. Um, People are crossing borders. People are communicating with each other on over the internet, over social media platforms. Everyone is talking about a lot of things, but one of the things that they're talking about is health and how um, a concept of health in, for example, one country is no longer limited to that country, but it's like all over. It's being communicated to people in other countries, and this has led to a lot of discussion on a formal level, an official level. You will talk about WHO, for example. It's a big player in global health. Then on a personal level, like you and I are talking about healthcare, despite being from different countries, right? So what we're talking about is how can we improve health across the nations. We're talking about economics of healthcare today, right? How politics across the world and within each country is affecting the healthcare outcomes. How social interactions are going to impact healthcare outcomes. How environmental interactions are going to impact healthcare outcomes. And how also like how we have these norms within our societies of defining people's position in society based on their wealth, on their race, on their gender, on their um, educational status. So all of those things together are affecting health, and all of these interactions are happening not just at the global level, but also at national level. Then there's a sub-national level. Global health is about focusing the interactions on the global level and how these interactions can be changed to improve health overall in the world. So I think that's how I would describe global health, and I think it's important to understand the complex nature of this field.
Yeah, thank you so much, Nabil Bhai. You explained very well the structure of the global health and the global health delivery. So before moving on, few participants have said us your voice is not clear. Can you please move the microphone near your mouth so we can hear you properly?
I apologize. I hope this is better.
Yeah, it's better now. Thank you so much, Nabil, for understanding. Now, move towards our second point of discussion is uh, we would move towards that is like Dr. Nabil, what do you think is global surgery and why people always, talk about the global surgery and reflect that as a neglected child of the global health. And what do you think? How is it such a tragedy that such a trending topic amongst the medical students and researchers is being neglected for so long, and why this topic is being resurfaced these days?
So, building up on the whole idea of global health, how it's about communication between people across the world about what is health, what is important in health, what is um, something that needs to be invested in, what should be prioritized within healthcare. The conversations that started initially, for example, I think it's after the World War II that WHO started talking about health as a human right. People also talked about cost effectiveness. It was for a very long time believed that surgery as a part not cost effective, which means to say that if, for example, I spend $100 on surgery, the benefit I'm getting is not at par with the benefit I will get by spending that $100 on some other aspect of healthcare, such as immunizations or um, nutrition. So that is one point. It wasn't thought to be cost effective. The other thing was that people did not think that the burden was too big. And then there were some people who just said that it's a privilege that comes later in the list. First, there are more important issues to talk about than surgery, and that's, I know, a very um, sad way of looking at healthcare and in general now that we think of it. But at that time, those were the conversations that were happening, and talks to you about the interactions again. So global health is all about interactions in the social circles, in the economic circles, in the political circles, um, where policies are being made about what should be invested. Um, and then it wasn't just surgery that was being ignored. There were other important topics like, for example, if you think about it, HIV was being neglected for a very long time, and HIV was neglected because it was thought that the treatment, even though the treatment was there, treatment had been discovered, the antiretroviral therapy. But the thing was that global health professionals thought that why should we invest in these treatments where the patient's going to just be a chronic patient, and is it really worth the investment? Will the community benefit from it? And it was easy for someone in the political circles or in the policy level circles to say yes, uh, we shouldn't invest in it. But for a person who was suffering from AIDS, or a family that was suffering from AIDS, uh, um, or a family that had a patient with AIDS, it was very difficult to accept this policy. And conversations happened between such families across nations, and these nations basically understood that we need to change this policy, and they started advocating for it. And by all of their efforts, we see that the treatment for AIDS became part of the global health agenda, and people started looking into it. So with surgery, it happened the same, but it was later. After, for example, like the AIDS thing happened in 1990s. Um, People started looking into surgical care as a healthcare aspect, and research was done, especially by the Lancet Commission on Global Surgery, by people like um Dr. John Muir in Boston, who is also closely connected with the people who did the AIDS effort. Uh, he's very closely connected with Paul Farmer. So these um, people, their research showed that um, 5 billion people across the world lack access to safe, affordable uh, quality healthcare, surgical care, and it was contributing to around surgical conditions were contributing to around 30% of the global disease burden, and more so that people who were suffering from surgical conditions were actually suffering from financial catastrophe and financial hardships when they went to access healthcare. There will also talk about how surgical lack of surgical care access leads to lack of economic development, a loss in GDP within countries and across the world. And these were very glaring statistics that were found. And then there was also talk about how these were impacting low middle income countries more than the higher income countries. And what was the reason? The reason was that no one had looked into improving surgical care. Everyone in the global health arena was talking about improving things like all of those things are important, like about how to improve uh, the treatment of tuberculosis across the world, or eradicating tuberculosis, eradicating polio, eradicating malaria, eradicating HIV. So to shift those people's attention towards an important topic like global surgery, a lot of research had to be done, a lot of advocacy had to be done. So 2015 is the landmark year for global surgery, when the Lancet Commission of Global Surgery released its report, which most of you probably know about. If you don't, have a look at it. They have 5 key messages that I've talked about right now. Um, the World Health Assembly actually passed a resolution that said, and this resolution is titled 68.15, which says that access to global surgery and strengthening surgical care and anesthesia care across the world is a priority. And it is part of the goal of universal health coverage. Like, universal health coverage is not complete without improving and strengthening the surgical care systems and the anesthesia care across the world. The third thing that happened within this year was another research based report coming from the World Bank and the WHO, the disease control priorities 3. This was and their first chapter and the first volume was completely on focusing on surgical care. They also shared some very glaring statistics about how lack of access to surgical care in health systems was resulting in a large burden of disease across the world. So if you also look at DCP3, it looked at the cost effectiveness of these procedures. If you, for example, they said that if you focus on 44 essential surgical procedures, you will be able to avert a certain amount of disease and morbidity across the world, and which all of these 3 things happened in one year, and that's 2015. That's when people actually started talking about how to improve surgical care, what are the challenges in surgical care access across the world, and countries. I think Zambia is the first country that took a lead on this, and they started assessing the disparities within their realm, within their national boundaries. And the idea was that using the information about the gaps, they will work on policies and they will work on investments and projects that will improve the overall access to surgical care across the country. And they followed the Lancet Commission on Global Surgery's recommendations to, measure certain indicators. And this was how surgical care actually started becoming a topic of interest. Now it's a trending topic. You will find a lot of people who understand global surgery, but I hope that makes some sense on what's important from this story is how the conversations that we have across um, platforms such as the IFMSA, or later on, if, inshallah, when you all are part of WHO, for example, um, and other transnational global health agencies, the conversations we have affect how certain topics are uh, prioritized, how we balance our priorities between the different needs, and this is like a prime example of how conversations lead to change and in policy, and then from policy to action. Currently in Pakistan, we are actually working on a national vision for surgical care with the government of with the federal government and with the provincial governments in Pakistan. So it's a growing topic, and I hope that you guys take more interest in it, because I am biased towards it. But yes, it's about, I hope you get the whole idea of how things become priorities in global health agenda.
Yeah, thank you so much, Dr. Amil, for sharing your personal experience regarding working of global surgery during your stay at Power and in Pakistan, and letting us know about the history of the global surgery. Now, I should move to my next question. I will ask you, as you mentioned, like you are working internationally as well as nationally on the topic of global surgery and working with the government. So, what are the challenges you face in improving access to surgical care around the world, and what is the eventual goal of the global surgical community? Like, for example, like you see, our governments are like very uh, step around, involving the young people and involving the external factor into that. They accept the high amount of aid, but that aid is not translated in the delivery of the hospitals and the healthcare delivery towards the patient. So, how you will address that issue? Over to
So
you.
thank you for that question. I mean, it's about so now we get a little more technical about how you approach the topics of like within this complex system of things that are um, existing, like the structures, the social structures, then the health system with its private sector, the public sector, then the government, and then the legal frameworks that are involved, the finances that are involved. Question is, how do you make sense in such a complex world? So what the Lancet Commission on Global Surgery did was it recommended that nations, look at. So they provided a 8-step framework for each country to follow. And this 8-step framework started from getting ministry support, number one, and then looking into assessment of doing a situation analysis, assessing the country's various domains of healthcare. So now we'll get a little more technical into what makes a health system, right? And what are the goals of a health system? Because this is important when you're understanding or when you're trying to achieve universal coverage of healthcare or universal coverage of surgical care. Um, so I would have loved to interact with you guys on this, but since we cannot, so I'll talk about it. Um, what is the eventual goal of a health system? So there are three major goals that are recognized worldwide. Number one is that it reduces disease burden and promotes health, right? Number one. Number two, it's that it is responsive. It satisfies patients' needs across the health, the population it's serving. Um, and it's also called responsiveness, because it's not just about satisfying people, but it's also about being able to satisfy people in a timely fashion. And the third thing is you ensure financial protection. Like finances should not be a discriminatory factor when it comes to populations accessing healthcare. And to achieve these three things, like any system, you need inputs. and inputs can so there are various ways in how people have listed these inputs. If you look at Paul Farmer's recommendations, he talks about space, stuff, and systems. And I hope you guys know about it. So space talks about all of the physical infrastructure that needs to be there. Facilities, where are you placing them? How are they distributed within the health system? Um, is it amenable to providing the care that is required by the community? Then there's staff. Staff includes people starting from the top, which includes the doctors and healthcare administrators and the public health officials that are needed, down to the nurses, and then you also have like the janitorial staff. You have so many other components within the health system staff that need to be focused on. Then there is stuff that you need to make sure that people are getting the medicines, the equipment required to provide the surgical care or to provide the healthcare in general. Then there are systems. How are you making sure that the care is being delivered according to the levels of you know um, quality that are required? Um, how are you coordinating between the HR? How are you making sure no one is taking unfair advantage of their position? All of these come within systems. So this is like a basic way of looking at health systems and the inputs required in the health system. Um, but the one that the Lancet Commission on Global Surgery actually uses as based on WHO building blocks. It talks about the same things but in different names, and it talks about 6 domains. You have infrastructure, you have workforce, then the service delivery, which is basically the combination of the different systems that are involved in running the healthcare system. Then there is information management. There is the governance framework and the financing. So these are the 6 domains that the Lancet Commission on Global Surgery recommended that countries should look into and then make recommendations. Um, they also kind of like set a benchmark for countries to follow. And this was all scientifically based. Basically, taking data from across the world, they looked at what is the minimum amount of surgeons required across a country to make sure that it has low surgical disease burden. And they found, for example, within the workforce domain, the target should be 20 surgeons, anesthesia, obstetricians per 100,000 people. So there's the scientific approach to it, and then this recommendation became part of a lot of the countries that have embarked on the national surgical obstetric anesthesia planning. They are targeting this indicator. So similarly for access, the indicator that they recommended was that access should be available to every person within 2 hours of their traveling distance, right? There were indicators regarding quality of care, which they talked about how every hospital or every country should actually be monitoring the perioperative mortality rate. So, as to say that they are actually monitoring what's happening in the overall outcome. And so those are some of the examples, like the indicators that were recommended. Um, why am I talking about this? Is because based on these indicators, based on these recommendations, we saw that uh, low middle income countries were lacking far behind in terms of infrastructure, in terms of workforce, in terms of the service delivery standards. They were lacking behind in the terms of the financing. A lot of people within the low middle income countries were suffering from catastrophic expenditure, impoverishing expenditure. Um, and the information management was not good enough, and people were able to kind of like um, not be competent and exist in the system. And there was no following up on what's happening with the progress. There was just like investment, but there's no information on whether there has been improvement or not. And finally, yeah, the governance structure was like full of corruption. These are the challenges that we face. And I think from a low middle income country's perspective, everyone knows about the corruption that exists within our political structures. Um, these are the ones that we talk about from a, so the ones that the six building blocks that I've talked about, these are health systems, right? Health system domains, these are health system inputs. The other challenges that we don't talk about in the Lancet Commission on Global Surgery, for example, but maybe we should talk about others, are the ones that are within the complex model of ecology of health that we've been talking about from the start. Have you ever thought about how our understanding of social norms affects access to care in our countries? How we do not know, but we inside have a racial bias or we have a discriminatory bias that we will not listen to poor people, but we will listen to people who can pay for their care. We will listen to educated people in much different ways as compared to what we will listen to in people who are less educated. Um, these are other issues that are affecting access to surgical care, quality surgical care. These lead to disparities within communities. Then there's the political structure. We see how for the benefit of a few, decisions are made that are not in interest of people, and the money that could actually improve healthcare access and can improve surgical care access, and appointments of relevant people that can improve access to healthcare and improve the access to surgical care, um, do not happen. And instead, we have incompetent people being placed in important positions. We have money being used for interventions that really are not needed in a low to middle income country perspective. Um, there's a lot of then this is like a separate paradigm that we have to look at the social determinants of health and how they are affecting the healthcare outcome within surgery or whatever is your interest as a physician or as a public health specialist, and how they're leading to inequities of care the within the community. In every country, you will have people who are getting the best of the care, and then you will have people who are not getting the best of the care. They're actually not getting any care, for example. That is where you need to focus on how to balance this inequity, right? And you can only do it by looking at health systems, number one, and number two, by looking at the social disparities and the social determinants of health on a larger scale. So I hope like it's a very broad a framework that I've been trying to communicate to you guys on how to look at challenges faced in achieving universal coverage of healthcare. And in my interest, it is basically universal coverage of surgical care. So how are we trying to face them? We've talked about it. Let's take the example of Zambia, how it used the 8-step framework, the National Surgical Obstetric Anesthesia Planning Framework, to kind of assess its country's situation on surgical care. And it did so by following the indicators recommended by the Lancet Commission on Global Surgery. And then based on what they found, they actually started prioritizing the interventions required to strengthen these areas. And lastly, they are now constantly like going back to studying what has been the progress within their countries. Other than Zambia, there are multiple other countries that have embarked on the National Surgical Obstetric Anesthesia Planning platform, and these include a lot of sub-Saharan African countries like Rwanda, and then there are countries outside of Africa. We have Pakistan being one of them, and it's a very interesting, growing area of interest within the international community. And every World Health Assembly, when people gather, this is one of the things that is brought up into discussions because of the community that has now become global surgery. I hope that helps you guys understand um, how we are trying to deal with the challenges and how we are looking at challenges. It applies to a lot of other healthcare aspects, global healthcare aspects. Over to you, Adil.
Thank you so much, Dr. Nabil, for your great insight on the delivery of the knowledge and our understanding of that knowledge. There is a really difference. We need to bridge the gap of that thing. So we would move towards our next question is, we received many questions regarding the achieving the universal health coverage as we are discussing the global health delivery. So I really want to ask Dr. Nabil, can we achieve universal health coverage and universal coverage of surgical care in countries like Pakistan and India, or maybe from Western Asia, Pacific region like Philippines, or like the countries who are struggling, in making their economy stable, and how we can provide our people with the best of the services that we only see in the developed countries?
You said something very interesting, Adil. It's a chicken and egg situation where you say that in economically resource limited countries, can we actually focus on healthcare? But the question is, if we don't focus on healthcare, can we achieve economic stability and economic development? We can't. Um, you need to really look at what drives us to be in this space of healthcare, in which we are talking about improving lives and improving well-being amongst people. We're trying to reduce the presence of disease, um, and the challenge is big, but mm, it is important to face it, um, and we need to face it because it's the right thing to do. Who defines why it is the right thing to do? Well, it's values that are common between all of us, and one of the values that we have um, is the value of ensuring equality and equity and peace and health, right? Making sure everyone gets their human rights. Um, it's very interesting how we tend to forget these values as human beings, and we end up seeing events in history of such as the tragedies of colonization, the tragedy of unfair treatment of racial minorities and ethnicities, how um, people are being treated still in the United States. We are seeing in developed countries, we are seeing how discrimination still prevails and structural racism still exists. Um, why is it happening? It's because we are not looking at life in a um, in a value based way. We are not looking life as human beings. As human beings, we should feel the need to go the extra mile to help the community. We need to look at how health is as much of a right for a unprivileged and a low middle income class citizen as it is for a high income country citizen, and as much of a right for someone who is uneducated as it is for a person who is educated. And there should not be any discrimination on religious and racial basis. This is what should motivate us. And yes, the question will come to you again and again. Are you sure you really want to do this? Isn't it a lost cause? Do you really think that you will be able to make a difference? Focus on your own life, make some money, you need to establish your practice. As long as you're able to take care of the people who are close to you, things are going to go well. Well, okay, but if all of us start doing this, who's going to focus on this important thing? And on another level, this is about helping community. You are part of the community. You don't know. Today you are lucky to be healthy and privileged and person with wealth, but you don't know your inaction may lead to uh, somehow you getting affected in the long run. Someone you love may end up getting affected in the long run. These are transnational times, global times, where you are connected with people in lower middle income countries as you are with people in the higher income countries. You don't know how uh, things will affect you in the future. So we can, we have to. And if we do not believe this, we will not be able to move forward. Understand the challenges, but do not forsake the movement. Um, and it's talk like this that will actually convert people to talk about this. And as I said in the start, it's all about communication. It's a global world. Global health is all about communication. The more you communicate with each other about the need to do this and about the possibility of achieving it, um, achieving universal health coverage, the more we are closer to our goal. Um, just going to really skim or just going to divert a little bit, and I think I've not mentioned this, but what is universal health coverage? Um, Adil, do you have any idea? I want to make this interactive. What is universal health coverage?
What is, sorry, I'm not
You-
able to.
What is universal health coverage?
Yeah, according to me, universal health coverage is, each and every citizen of that particular country should be able to access the emergency as well as the basic healthcare free of cost, and at any time, whenever he steps into the emergency or indoor or outdoor patient services, he should get the best service available for his treatment. That is
That
according to
is
me.
really like the crux of it. I'll give you a little more insight into what universal health coverage is. Um, and I would recommend you guys look into this. It's about three dimensions, right? Um, three dimensions. There is a dimension of the services that should be present, right? Then there is a second dimension of the quality of these services. And then there's a third dimension of access to these services. And access includes like what Adil said, like nothing should come into play, nothing should come into the way of someone trying to access care. Nothing should obstruct access to healthcare, right? So, need to focus on improving healthcare through improving the services and number of services available, by improving the access to these services, and by improving the quality of these services. Something practical about how we are trying to achieve universal health coverage. I don't know how many of you have looked at disease control priorities 3 and their goal, but what they talk about is how the journey to universal health coverage is not just about no universal health coverage and then universal health coverage. What they're doing is, what they've done is, they have recommended a midpoint, which is universal to essential health coverage, right? Um, so this essential universal health coverage is basically a set of services. These are not all the services that you will want in an ideal universal health coverage situation. But these services, if you focus on them, and you improve the access to these services and the quality of these services, the major work is done. That is what the DCP3 talks about. Once work on the essential services and the high priority services, eventually there is a hope that you will reach a point where you are providing all services across the country. Another practical thing how universal health coverage is being the target of universal health coverage is being approached is about using the private sector. Um, the government, for example, is not able to provide care within the country through its public sector um, hospitals, and it's okay. It's something we are living with. Shouldn't be the case, but it's something we are living with. But at the same time, in countries like Pakistan and India, where the population is growing, we can understand. Okay, it's a challenge, and coupled with hundreds of years of 100 years of colonization and the degradation that it ensued, and the different political um, difficulties we have, it's okay. It's fine. We don't have the public sector is not good enough. How do we tackle this situation? How do we achieve universal health coverage? One of the um, approaches is actually using the private sector. And what the government is doing in Pakistan, for example, is that it is providing insurance to all of the people who are uh, unable to afford care and who are at risk of going for financial catastrophe or financial hardship when they access healthcare. By doing so, what they're doing is that by insuring these people can now access care at private sector, but they will not have to pay anything. The government will pay the private sector. It's a very interesting model. So solutions are there, and it's about being innovative. It's about being motivated, and it's about understanding this area if you really want to see if we can achieve universal health coverage. Long story short, yes, we can, and yes, we have to. So yeah,
Yeah. My mic was mute.
yes,
I was sorry for that. So, we have received a question in the chat box regarding your universal health coverage. One of the participants, Sukanya, says preventive aspect is more effective in developing countries if we following the sustainable developmental goals. If we are following to achieve that SDG 3, how to convince the government for global surgical plan instead of global readiness? I can.
yeah. Do share the question as well, but I
Yeah,
get
yeah.
the crux of it. So Sukana,
So Kanya.
Sukanya. Okay, thank you for the question. So universal health coverage. Um, there is definitely prioritization of services, but the prioritization is no longer based on just knowing what is preventive and what is curative. And prevention itself has, you know, its type. There's primary prevention, there's secondary prevention, there's tertiary prevention. Um, Surgery does play an important role in secondary prevention. If, for example, a fracture is not treated, we will see someone losing the productivity they have, and this will impact economy. Um, so, how the government should be approached? The government really looks for um, evidence-based suggestions and recommendations, and those that are validated not just by people within the country, but also they give preference to something that has been tried and tested. By using the correct actors and agents within your society, and approaching the government through those actors and agents, you can make the government look at the evidence that exists on how surgery is an important component of um, universal health coverage, how it needs to be given priority, how it is cost effective, how it is addressing a large burden of surgical disease. Read up on the literature. The DCB3 recommendations and its first volume on essential surgical services is essential surgery is something it is accepted worldwide. It is being recommended on multiple national and international forums. Um, More so within the World Health Assembly, and these are like the three landmark events that I mentioned initially in the question about how global surgery came into mainstream. talk. So DCP3 started recommending governments to, focus on surgical care. Lancet Commission on Global Surgery interested people into studying surgical care access within their countries. And then the third big thing that happened was the World Health Assembly Resolution 68.15. Countries who are part of the World Health Assembly, which include uh, all countries, um, practically all countries, they they actually signed on that resolution, and then they accepted that they do need to focus on strengthening surgical and anesthesia systems and access to surgical and anesthesia care. So these are some tools that you can use, advocacy tools, and the research, the evidence, and then the resolutions. These are the tools that are being used within other areas of healthcare and global health. And global surgery has to use the same tools, and we do. We make policy briefs out of these evidences and present it to the government. We use national level data as well to provide evidence to the governments within different countries about how surgical care needs to be focused and how it will benefit the country in the long run. So yeah.
Yeah, thank you so much, Dr. Nabil, for explaining that beautifully. So I would move towards our next point of discussion is, um, we talk about discrimination in healthcare and different aspects regarding the safest delivery of the healthcare services to the population. But how do we work towards making healthcare more inclusive, towards the people of all walk of life, irrespective of their gender, sexual orientation, or maybe socioeconomic status, especially in lower and middle income countries like in India and Pakistan. And you have been working in the hospitals, like, we put the patients in their boxes and people in their boxes just because of their based on their color, skin of color, they're fair or they're black, or people like that. People do this thing and the common thing, or based on the language and stuff. So how we should, as healthcare professionals, make sure the safest way of delivery of healthcare services to the population?
A very important question. Impacts not only you know certain countries, but it's impacting all countries these days, um, whether they be developed or developing or underdeveloped. Issue is that you, as human beings, when we get a little bit of power, or when we start looking at people, we start looking at how much power we have over them and how much uh, power the person in front of us has, and we communicate accordingly, which is a wrong way. And this is what racial bias is. And this racial bias is not something that we are born with, but something that we kind of pick up as we live in a society where um, the problem is more structural. By structural, I mean something that you will see in various institutions, not just in healthcare, but in you will see this problem within education. We will see this within your social interaction circle. You will see this within other issues. If, for example, within housing, within financing, within job employment, you will see that certain communities and certain people are being discriminated, and it will become a norm, and you won't even realize it, but you will start considering or you know associating that norm with the patients you are dealing with. This is what we call structural racism, which is prevalent in the subcontinent as well. We will see that doctors that we work with, on a, from a Pakistan perspective, I can talk about this. Um, we see that doctors have a different, some of the doctors have a different attitude towards poor patients and a different attitude towards wealthy patients. They have a different attitude towards educated people and different attitude towards uneducated people. Um, to so much so that even if the services are available, they're free of cost, and there is a potential to provide quality care. You will see that A person who is poor may end up getting a poor outcome as compared to a person who is wealthy, or a person from a higher social class position based on just the ethnicity or their religious background may actually end up getting better care than someone who is not. Um, how do we even start? We don't recognize this as a problem. Uh, it's such a norm within our communities, and this is something I really want to talk about in this seminar is about structural racism. That since it's part of the media, it's part of our jokes and our memes on social media, we end up not giving equal importance to every person, and this impacts the type of care we are providing to our patients and the type of care we will provide to our patients in the future. What can we do about it? There's a very interesting paper on this about addressing health inequities and from the American Public Health Association. And I'm thinking, Adil, maybe we can list all the different articles that we were been discussing in the background with the people who have attended this webinar through our social media page and through the email. Um, so this two pager actually talks about how we need to be explicit in acknowledging that structural racism, structural racism exists within ourselves and within our families and within our communities. And it's not something because we want to downplay or um, because we want to criticize ourselves only for the basis of criticism, but it's about being constructive in our approach. We need to find ways of changing ourselves and changing our institutions and changing the people around us. Because until and unless we do not change or talk about this and communicate with each other about what is right, um, we cannot bring these things into practice. We are affected by the social norms that we are surrounded with. That's the whole point of um, a society, and how public health is trying to address it, or global health is trying to address it, is by changing its definition and talking about how we are part of a complex system, how our interactions lead to some people becoming, disadvantaged and some people being not. So yeah, as IFMSA, for example, like within your institutions, you might want to look into how these things exist. They do exist, you know them. Start calling them out, not for the sake of criticizing, but for the sake of uh, being constructive and for improving ourselves. Um, do maybe, for example, education sessions on it, find out resources that can be used to counter the racial prejudices and the structural racism um, that have proven effective within different countries. So, um, yeah, that's the only way we can actually approach inclusivity. We can approach the different the I'm not the dirt of racial discrimination and discrimination overall.
Yeah, thank you so much, Dr. Nabil, for discussing this pertinent topic of discrimination with us. I do believe social accountability is the only way where we can move forward, and we do need to call out, but at the same time, we need to keep that in mind. Criticism always should be constructive. It should not be destructive, and it should only be able to clarify your point, not to totally target other people. So I think we have covered the major aspects of the global surgery and how achieving universal health coverage, or the essential universal health coverage, which we learned today, is necessary for making the country stable in terms of economy and its social structure. So now I must ask Dr. Nabil, tell us about your journey. How has this journey been with you? Work studying a student from Aga Khan, and he out of the sudden he is following his passion for the global surgery, and he has reached Harvard, and he has been the research associate. Now he is following his passion is in the form of Masters in Public Health at the Harvard School of Public School. So please tell us your experience, how you will describe the students, aspiring medical students who have gathered here to listen to you. Please share your experience of research, your experience of your, following through the admission process and stuff you would like to share with us. Thank you.
Okay. So before I start talking about a journey, that I just want to clarify some things. Everyone has their own journey to live. You control a lot of decisions, but some decisions are already made for you. Um, you often worry more than how much you need to worry about, different things. Um, this is part of being a medical student, and it's normal. You all will come out great as people and unique in your own way. Never compare yourself with other people. And just keep working hard and trying to do what you think is right. And yes, there will be moments where you will feel like you are not doing your best, which is okay. No one does 100% best all the time, right? We have our phases. So for me, not a very, I was not a very bright student within AKU, but I always had a, I should say, I did have a passion to serve community. Um, I was not part of IFMSA, but I was part of a different group of students who went into the community and did healthcare, did health camps and health education sessions with students from um, underprivileged areas within public schools. We ended up finding that there were people, there were children who were who were like 6, 7 years old, but they had never had a vision test. And when we did their vision test, we ended up finding that they needed classes, and we gave them classes. And I realized that problem of healthcare is on a national level is just something that cannot be tackled with individual medicine. Um, but at the same time, being from a country where public health is not given that much importance, and um, what is given importance is specialists trained from abroad. Um, I had to start thinking of what individual medicine specialty I'm interested in, and I found myself looking into surgery as like something that interested me. And then surgery and public health, I tried to find a synergy between these two. Ended up finding it in some of the people I have come to know as my mentors. Dr. Lubna Samad is one of the people in Pakistan who is a surgeon, but is also working on global surgery. She is championing the whole national vision for surgical care effort with the government of Pakistan and in collaboration with the Harvard Global Surgery team, the programming Global Surgery and Social Change with other international figures. So I saw her and I was like, interesting, she can do it. She's balancing surgery and public health. So I kind of like attached myself with her right after graduation. I did do my steps, did my step one before joining her, and also did my step to CS. I want to do clinical surgery, and I'm applying for the match this year. The reason is for training outside is because I think it does give you an edge over. Training will definitely help you later on if you want to also cater to community on a individual level. So ended up working with Dr. Lubna for 2 years on a grant based project. We did a household survey across Pakistan. We did a patient survey across Pakistan's tertiary care hospitals, public tertiary care hospitals. Went to Faisalabad as well, but never met Adil over there. But yeah, I mean, like, it's been a journey I've traveled throughout the country now, and got a better understanding of how population dynamics are different within the country, and how um, public sector is also, the challenges unique to the public sector, how people are different but not so different in their challenges. Um, So as I was working on this project, I got to interact with a lot of collaborators who work with Dr. Lubna Samat, some of them being from Harvard Global Surgery and Social Change, Harvard Program in Global Surgery and Social Change. That I got to meet Dominique, who's like a very interesting person. In parallel to IFMSA, he's running Incision Global, Incision International, and some people from Egypt, some people from Africa, some people from, and through them, I just decided I need to go into this program as well. So I applied to their program. It delayed my application to surgery residency by 1 year, but I was like, sure, why not? Like, if I'm into it, I should definitely take the whole flavor of it. So 1 year with Dr. Lubna Samad at Indus Hospital in Pakistan. Someday maybe we will talk about Indus Hospital and Indus Health Network and the story about it. But through her, I got to understand government structures within the country and the ENSO frameworks and the global surgery movement and the global health movement. Then applied for the program in global surgery and social change, which I got accepted, and then I spent 1 year there from June, from July of 2019 to June of 2020, and in between the pandemic hit, and I was stuck in Pakistan and ended up working on the pandemic efforts within Karachi. And then during my time at programming at Harvard Medical School, programming global surgery and social change, I ended up applying for the masters in public health. It was a 1 year. So masters in public health, you will have like 2 year programs, and then you have 1 year programs. 1 year programs are very few. Harvard School of Public Health is one of the few programs that provides a 1 year MPH, and that is only for medical graduates and people who are related to health sciences. Hopkins provides a 1 year MPH, and then you have Yale that provides 1 year MPH, but Yale also just does specifically for healthcare professionals. Hopkins does it for everyone. Anyone who goes there gets it done in 1 year. So these are the three places I applied to. Was lucky to get full scholarship at Harvard, and that really made my life easier, and I had no option but to go there. So we've started our summer courses at HSPH, but it's different because of the whole pandemic effort. So that's been my story. I did not plan this on the first day of my med school. I did not plan this on the last day of my med school. This just happened. I just knew that at the end of the day, what I really want when I'm done with my training is that I want to be a surgeon, and I want to be someone who has played an important part in improving healthcare within communities. So for that, I need to do public health. So synergizing both of these passions, I just start making decisions. I could have gone into surgery residency and then looked into public health, which is an equally good way of going ahead of with life. But sometimes circumstances just push you towards another way, and this was the way that was appropriate for me, and I am happy that it's been great. So yeah, this is how my journey has been up till now.
Thank you so much, Dr. Nabil, for sharing your amazing journey with us. And now I must move towards the question that we received in the chat box, and I have posted here also. Neil asked, how we as a future healthcare providers can strengthen the surveillance system of proper delivery of healthcare services in the rural areas of developing countries. Like, for example, in Pakistan, we expect to 60% of the population lives in the rural areas. And it's really hard to talk about those people because we are always taught in English or other languages. And when we move towards the rural area, especially when we move towards the Sindh or when we move towards the inner Balochistan or Punjab, the languages are very different, as the same situation we face in India also when we move towards the Maharashtra or when we move towards the south of the India, and when we move towards the extreme north of the India. The languages, the cultures are really different, what we face in the medical schools. So how we incorporate that into our knowledge and we interact with the patient at their level.
It's a very interesting question. Rural area health care. Um, so for any public health challenge that we face, and rural health or rural area population is a population level health challenge, right? Access to healthcare within rural areas or to the rural population is a population level health challenge. So you need to look into the basics of public health. Um, what does public health teach us on how to approach a problem? And the idea is that you need to first study the issues, right? Not just from your perspective, from a scientific perspective, but from also a perspective of the community. Uh, Within each community, you will always find someone who will be able to talk about the issues that patients face. And we, as public health professionals within our society, especially in Pakistan and India, for example, I think we tend to dictate a lot, but we do not listen that much. We need to develop a ability to listen. And this is in the current context. In the short term, what we really need to do is to look at the public sector system and see the distribution of health facilities and where they are located. Now I'm shifting towards the global surgery framework of 6 domains, right? You look at infrastructure. How is infrastructure really available within the rural areas? Uh, that rural area populations are able to reach a hospital within 2 hours. How do you understand this? There are really interesting geographic information system studies that have been done in other parts of the country, which have which have used geographic informations of the facilities and the population level data of the country to see which areas are underserved and which areas are not underserved. And in the underserved areas, you develop the facilities because that is where facility is lacking. Then you also look at things like um, within these facilities, if they're existing, is the workforce there? A major problem in Pakistan is that rural health in rural areas, we have very good plans for district level hospitals. We have plans for accommodating workforce within these areas. You have within the structure of a district level hospital, you have residents for people from urban areas who will come to these rural areas and work, surgeons, anesthetists, gynecologists. And but the truth is that you don't have these things. You will have I think 40% of Pakistan's rural area district hospitals do not have a gynecologist, right? um, and if they have a gynecologist, they will not have an anesthetist. So for example, a person who needs a c-section may not end up having a c-section because there was no anesthetist. I've been to, for example, this very poor district within Sindh, within Pakistan, Tharparkar. In within this district, there's a tehsil called Chachro, and I saw the plan for that facility, the tehsil headquarter hospital, and I was like, they had planned for residents for workforce, but no one was coming there. And the residences had actually not been maintained. Finances were not being provided to that particular facility. So brings you to the other aspect of looking at what the financial flow of resources is to the hospitals within the rural areas, and then building more on this, you also look at the information system. Are people being monitored for the services they are providing within these areas? You look at the service delivery standards. How many procedures do they conduct within the hospital? Very interesting is how in a study within Pakistan, within the Sindh province, they found that um, gynecologists were actually diverting patients from the hospital from the public sector hospital to the private sector hospitals, and by that way, they were actually getting better paid. Um, the services they would provide as a doctor within the public sector hospital were subpar. They were discriminatory, but within the private sector hospital that they were practicing at, they would do really well. So shifts you to the more important topic is about governance. I think within India and Pakistan, I don't know about too much about India, but within Pakistan, what we are really struggling with is our lack of will to change things. I don't think we have a shortage of resources. I don't think which we cannot fulfill in terms of workforce or in terms of finances or in terms of facilities. What we're really lacking is will from the government to actually enforce, a, you know, enforce quality standards on the types of services being provided, on the types of services, on the types of activities government employees are supposed to do. And it's also about motivating them. When it comes to language, you really can involve community leaders and community folks to, improve the cultural gap and to, and that's the only way. I think if someone's really interested in rural healthcare, may want to look into how they can actually develop a rural healthcare curriculum for people uh, relevant to those areas in which they show how to learn languages or how to communicate when you don't know a language. And I think there are very interesting ways of how you can achieve these goals. Um, I think India has a really good rural health surgeons program, which is being highlighted across the world. And I have read about it. Um, Maybe look into that.
Sorry, Nabil bhai, I just want to ask, your voice is not clear.
Um, how?
Yeah, yeah,
So
it is now.
this is better.
Sorry.
I'm so sorry. I'm so sorry. Internet issues and trying to navigate this whole Zoom life. I'm. I hope you guys get the context of how rural healthcare is just like any healthcare. You have to look at it from a um, framework, and the framework you can use is the six domains of healthcare or the six building blocks of WHO that are also part of the Lancet Commission on Global Surgery. And through that, you can, and then you have to involve the community in making policies. When you're involving the community, you can talk about the challenges they face when it comes to service delivery, when it comes to communication. Um, And to address that challenge, one of the solutions is to integrate cultural competence and to integrate how those language literacies within curriculums for people working in rural areas, motivate them to, go the extra mile.
Thank you so much, Dr. Nabil, for your insight. Now, I must ask the question. This is from Disha from India. She's asking. They had like two schemes. I think she hasn't mentioned that where. I think in government or maybe in IFMSA of public health, and they were working on the issues of tuberculosis and malaria. But the framework on tuberculosis did very great, but the malaria didn't. So she is asking where it's more efficiently yielding the, yeah. She's asking where to put our money, where it's more effectively yielding results, or where the results are worse to uplift them, like where to invest.
So I would recommend you, if you're really interested in knowing about this, to look into health economics. It's a complete field in which you have measures of disease burden on a population level, and based on outcomes from various programs in different countries, you basically see, for example, if I invested $100 in improving care for tuberculosis in a certain country, and over time I saw that there was a reduction from 10 dallies to 5 dallies. The benefit I see is 5 dallies divided by $100. For each dollar, I see that, there was a certain amount of benefit, 5 over 100, 1 over 20, to, I guess, 0.05, right? So the that is a whole field that exists within the global health community. You will see the effectiveness of interventions such as malaria netting, or interventions such as, like, the DOTS program. Um, these interventions have been costed. They have been also looked at from how they have reduced the disease burden, and then you can basically compare the cost effectiveness. So cost effectiveness is what the within the literature is where your answer lies when you're comparing interventions. Controlling malaria and controlling TB is like a vast array of interventions exist, but choosing the right intervention, the intervention that will suit your population, is something you need to look at. And yes, you have to make those decisions. Um, it'll be interesting to explore more literature on what exists and what does not yield
Yeah.
benefit.
Thank you so much, Dr. Bill, for your great insight. Now, Dr. Mohsin Khalid, he is a recent graduate from Pakistan. He is asking you, is the program for global surgery is competitive, and what are the prerequisites to apply for this position? Um,
So the program in global surgery and social change, it's part of the global health social medicine department at Harvard Medical School. It's separate from Harvard School of Public Health. Harvard Medical School has multiple departments. This is one of the big departments, global health social medicine. Within this department are sub-departments that focus on global health issues. One of those departments is programming global surgery and social change. It is a competitive program. It is actually a non-paid position, which is a big issue if you are applying for it from a low middle income country. um, you can go to program global surgery and social change either through the research associate position. That's a 1 year position that you are competing with medical students and recent graduates from recent graduates from across the world. And what really they are looking for is people um, who are interested in changing the paradigm of healthcare across the world, by their passion, by the way they write, by the way they act within their communities. And if you have those things, it's definitely worth applying for. And I guess finances is an issue, but you can figure it out if you, for example, do get accepted. Maybe some way you will be able to manage yourself and get to that position. But it's really about passion. If you're really interested to apply for it, the other approach to becoming part of this program in global surgery and social change is, if you're a surgical resident and you want to take 2 years of research break, so you apply as a research fellow. You're given more responsibility as a research fellow, and it's a more structured commitment of 2 years. So those are the two ways you can apply. It is competitive, obviously. It's a Harvard-based association, and but what can really make you stand out is your passion for improving healthcare globally, locally. Something that you've done, make connections within your own community of global surgeons, and see if you can connect with them. Connections matter a lot. Um, you can have a lot of work that you've done, but if you've not communicated it and you've not shared it with people, to the different circles you're involved in, it really doesn't count. Doesn't give that impact. So start talking with people. It's the more competitive it is, the more the reason to apply for it and see if you really can work
yeah.
hard. And yes, it's not going to be easy, but you can do it.
Thank you so much, Dr. Bill, for your insight into the program of Research Associate and Fellowship. Uh, I think we have concluded all the questions here in the chat box. And guys, the floor is yours. And if anyone wants to ask the question they can open their mic and ask the question. but it has to be civilized and in a very structured way. So if anyone wants to go, they can type their name in the chat box and I will allow you to go first. So meanwhile you are doing, I will ask the question. As we are live on the YouTube, many people have asked us regarding the role of, especially the undergraduate medical students or the undergraduate healthcare professionals who are to be the future healthcare professionals. So how they can play the meaningful role towards achieving of the concept of essential universal health coverage. How we as medical students can play a role.
I think I've talked about this maybe briefly. If I haven't, I will repeat and I will discuss this. I will still come back to what I started with, how global health came into existence, how it is being operated is basically based on communication, effective communication between peers, and about how can you improve access to certain aspects of healthcare and what is important within healthcare and how healthcare is a right. This conversation between people and has actually changed a lot of mindsets, and as people have changed, power lies with the people. As people believing in this concept increase, the power in this concept increases, and when the power increases, people have to yield to um, this need of the people. um, the thing is, there are things that are stopping people from improving healthcare, and you have to identify those and realize that you're fighting against these certain interests. um, these people are uh, have power as well, and the power is basically the power to divert funds to their interests, the power to make sure that the money does not go to the area that requires it, because there is some vested interest for them. um, and such interest could actually be something, for example, like their political interest. For example, the interest of pharmacies is in making sure that patents do not expire, or when they expire people do not get to know about it, or that they're not demanded to or that other pharmaceuticals in the local get most money. And that is what was happening when you talk about um, the challenge with providing care for AIDS patients and HIV patients, is that patent had ended on the antiretrovirals, but no one was talking about it, and the whole matter was being like shoved into ignorance. And um, as a result, the companies that were actually manufacturing the drug, or were allowed to manufacture the drug from the start, were the only ones manufacturing it. They were controlling the prices. um, Certain individuals actually found out about this, and they started promoting this information, eventually leading to other pharmaceuticals, you know, making these drugs and bringing the price to a range that actually worked. So these are the powers you're actually, struggling against. And the only way that you can uh, face and fight these unjust forces is by talking about justice, talking about um, fairness and healthcare as a right, and about human rights. And that's what we're doing right now, and that's what you should be part of our lives as healthcare professionals. And in these discussions come up areas which really resound with you on a personal level, and then you start working on those areas. And these you for example get focused on a particular part of the world, or you get focused on a particular aspect of healthcare. Whatever it is, it just promotes interest, and as you start discussing these things, you will find that other people also have their own interest. Eventually, when we all talk about the same thing, about healthcare, about fairness, about justice, about equality, about equity, universal health coverage will become possible. And yeah, it's about engaging with each other, advocating for the right thing. That's what you can do, and you guys are doing as IFMSA, and that's great.
Thank you so much, Dr. Beal. Now, Priya Bharat wants to ask the question. Priya Bharat, the floor is yours. You can ask the question. Priya Bharat, are you in the call? Okay. There is one more question in the chat box. Is people want to work with Dr. Lubna, and they are saying if there is any way they can approach where she works and stuff like that. So can you please guide them?
You guys can contact me, whoever it is who wants to work with Dr. Lubna, and I will connect you guys with her.
Yeah, I think we have discussed most of the questions. So, uh, participants, if you have any question, okay, Adira, go ahead. Floor is yours. You can ask. I ask the question, please. Oh, okay. No, she was asking about, yeah, her question has been answered. So, if any participant has a question, they can ask that. Okay, Vedant Shukla is asking, how far do you think we are in the dream of achieving universal health coverage in lower middle income countries?
Hmm. Interesting. Um, it's a concept that, okay, so universal health coverage, you really have to kind of put a boundary on what area you're talking about. And the lower middle income country is a big boundary. And if you break these boundaries down, you will be able to see that the progress is very varied and very different within different regions. And you will have the African sub-Saharan areas, and then you'll have the lower middle income countries of the Southeast Asia, and then you'll have the Wipro region, the Pacific. So you have to really look into regional areas, and then within regions you look into nations. We definitely really like the target for the sustainable developmental goals is to 2030, right? But I think we are another 10 years in short, falling short. So guessing we have to do a lot of work. This generation may actually bring change if we continue talking about these things and building up each other. I, for example, see myself actually being able to make impact, for example, in 10 years, and start making impact in 10 years, and then put another 10 years, maybe 2040. That's just like a random thought that I'm thinking of and thinking aloud. But you can't really tell. It's just such a vast um, um, domain, and I think if you follow what the um, targets of universal health coverage are, maybe that can improve our understanding of achieving the outcomes of universal health coverage. Maybe look into um, have we reduced health diseases to the level that we want to? No, we haven't. Are we responsive and prepared for patient satisfaction? No, we aren't. We saw what the pandemic did to us. Across the world, we saw how we were not ready for taking care of surge on the health system. Then the third thing is, are we seeing financial risk protection amongst people across the world? No, we are not seeing that either. We are very far away, definitely far away. But we should aim for 100%. I don't know if we can get there, but it's the journey that counts, and the first step is the most important. We have taken it. We should just like keep moving forward and trying to look for the eventual outcome. we have the direction as well through such various literature and such various, um, frameworks that I've talked about today. It's about following them, and let's see where we get. I'd say 20 years, just for the sake of it.
Yeah, thank you so much. So there is one more question is, are there any success indicators to achieve the success rate on achieving this agenda 2030 every year? Like, are there annual success indicators for our countries? Have government?
So the World Bank data is one resource that you can look at. The World Bank data presents um, indicators such as expenditure. So from the Lancet Commission on Global Surgery, for example, they adopted the proportion of population that is at risk of catastrophic expenditure and at risk of impoverishing expenditure. So maybe look at that resource. It provides other information on catastrophic expenditure, impoverishing expenditure, which is a major component of major outcome that universal health coverage is trying to address. Then the other resource that we can look at is the global health, um, global burden of disease, the GBD database, where you will find statistics on access on the burden of healthcare of diseases, the burden of healthcare diseases, in terms of mortality, in terms of mortality and morbidity, and in terms of the risk factors that are present within the community, within different nations, and you can compare them. And so those are two interesting resources that you can look at.
So much, and they both ask the same question. So I want to ask the last question here. So what do you think? We have discussed the whole idea of global surgery, and it's being neglected, and now it's being the center of the study around the world. So what do you think? What is the one biggest target we need to achieve, like in Pakistan or India, stuff like that, if we are working? So what is the biggest thing, according to you, we need to work on? One thing.
There is no, so that's the whole idea of this conversation of, I guess one take home message from the whole webinar is that there is no one solution. And the problem is not a linear problem. It's not something that will improve by just one intervention. Um, it is the problem of healthcare access and health and disease within countries and within nations and within and globally is a result of complex interactions between various social structures within the health system, within the interactions between the social structures, the healthcare system that exists within that country, um, and that results in the burden of disease or the burden of access, care disparities, or um, the lack of access. What we really need to do, I guess, is understand this complex nature of public health problems, of the problem of access to surgery, and talk about the need to focus on uh, the various other areas of society that will eventually impact us in terms of improving healthcare, right? So we will not be able to achieve economic growth without improving healthcare. Similarly, we cannot improve healthcare without focusing on economic growth. We cannot improve workforce and healthcare without focusing on education, primary level, secondary level. Um, so understand these complex interactions and this is what as this is another thing that is happening in the global community, is that they are trying to push for healthcare being being indicator for policies that should be adopted and should not be adopted, right? For example, like policies that are health friendly will always be beneficial. Policies that are not health friendly will not be beneficial, whether they be within economics or economical circles or within social circles. So that is the debate that's happening. We really need to change the understanding of the problem um, within us, and I guess especially at the you know the the government level, maybe that will really spark some change.
Yeah, thank you for the great insight. Now, we don't want to ask a question from you, Vedant. Go ahead, the floor is yours.
Yeah, am I audible?
Yes, you
Yeah,
are.
sure.
Yeah. So I've been following a lot of activities that Adil is been doing for the past few months on global health and universal healthcare coverage, and amazing work on awareness about that. And in one of the webinars he had arranged, there was a talk about how global surgical care can sometimes push towards more environmental change and climate change. Like sometimes the need for anesthesia can cause climate change. And there was another a research associate from Howard who spoke about that and increase production of instruments and stuff that would use plastic and stuff like that. So, how do you think we can tackle the issue of climate change with increased need of global surgical care, given that environmental and climate change can push global health more back in the journey towards universal healthcare coverage?
Yeah. Thank you, Vedant, for this interesting perspective on the impact of planetary healthcare and on impact of environmental, uh, um, challenges that and how they impact access to surgical care. Yes, it's very interesting to think about the instruments we use, for example, and how they're being sterilized, and how, like if we're using plastic, how appropriate it is, and are we increasing the non-biodegradable, materials that we're using. So, same, it's just something that we need to ask on first, very individual level, then on an institutional level, and then on a government level on how we can approach such problems. Um, it's very, it brings us back to the whole point of how we need to have a holistic approach towards the issues of healthcare. And again, I stress on every one of us looking at the ecological model on how healthcare problems, be it surgical care problem, anesthesia problem, are basically a result of not just us being like in the hospitals, but also as us being in the community. Within this, as an answer to this question, maybe we should talk about plastic-friendly hospitals or environmental-friendly hospitals. How we can use reduce cutlery, for example, cutlery that is being used in the hospitals. How we can promote use of wood-based cutlery, or things that are very interesting. Things are happening within the environmental health and environmental sciences domain. So some suggestions. It's all up to you guys to think about, and if you feel really strongly about it, push for it.
Yeah, thank you so much. That was actually Lotta that discussed that perspective on that climate change and use of anesthesia and the surgical industries being affecting the planetary health and stuff like that. So it's good we actually reflected on the work of Lotta too. So I think we have mostly concluded the question. So if we have like home take message, we already discussed that actually. We need to understand the understanding of that disease pattern, and we need to understand the bias of the healthcare profession, as well as we need to understand the demographical structure of that country or the area where we are going, where we have to perform. Like if we have to treat the patient from United States, or if we have to treat the patient from interior rural area from India or Pakistan, the needs of those patients would be totally different. So we need to totally understand that aspect too. So I think we should conclude the call. If you have any closing remarks, so we should do that. How you felt that? How's your
This was really energizing whole activity for me as well, and I hope it was for you guys as well. Adil contacted me like a week ago, just connected because of Lota, and like it's very interesting how our network is kind of like so interconnected globally. We didn't know each other, but we knew friends, common friends, and that's what we need to really cherish. At you guys need to cherish at IFMSA, and through IFMSA, you can actually start getting in touch with other people. I think Adil and Arsalan have done a great job in arranging this whole project, and the impact of this project, though it's very difficult to measure, but it's definitely there. It will be something that will impact lives in ways that we may not comprehend today. And to everyone in this call and watching this webinar, it's just thank you for giving me the opportunity to talk about this, and I hope you guys also put forward this whole agenda, this movement in front of your other friends, and propagate for healthcare for all across the world, and surgical care for all across the world.
Thank you so much, Dr. Nabil, for your time. We know you are really busy in your virtual master's in public health classes, and we are really proud of you for achieving what you have achieved, because at the end, it is taking our country's name forward, and congratulations on that. And I want to congratulate Arslan too, because he has worked really hard for that. And also our amazing participants for being so structured and listened to us so nicely and followed all the process with us. And for this, I will ado, and in 10 seconds, I will conclude the call and cut this Zoom section. So we will conclude the call. And thank you so much, Dr. Nabil, again for joining us. Thank you so much for your time.
Thank you so much. Thank you so much. Take care, everyone. Bye.
Yeah. Good night, good evening, good morning, wherever you are. Have a nice day. Goodbye.